think we can start. So actually we are already recording this session. So welcome back, guys. We are going to listen the next keynote speaker, Professor Tomei from University of Pisa, working on the analysis of complex system, on the social analysis of complex system. So today is going to talk about the social impact of medical technologies. As for the other speakers, if you have any question, feel free to turn on the mic, and for sure at the end of this presentation we have time for question. So Gabriele, you can go.
Okay. Thank you, first of all, Carmelo, for your invitation in this winter school. I'm just external to the central topic because I am a sociologist. I'm not an engineer or a specialist in a certain way about medical technologies. But in this presentation, I will try to show you what is the meaning of the impact, social impact of some policy, in this case, some devices. And so we have to merge together the first concept about social impact and the second one about what social impact means in medical technology. So my presentation is organized in several points. First of all, we will focus about the concept of social impact. It's not is quite easy to understand in a very common sense, but reflecting about social impacts help us to in-depth into the complex systems development. So we have to just to focus what is the meaning of this concept. The second one is about medicine technology. There are some contribution in literature that show us how medical technologies is not only one type of things, but there are several types of medical technology, medicine technology. And then we will start about how to analyze the social impact of medicine technology, and we will understand better the barriers, the enabler factors, and the outcome of this medicine technology, and then the impacts of this type of technology, firstly on the doctor-patient relationships. That is the first environment, very crucial, because this type of technology change the attitude of the doctors, change the attitudes of the patients, and then the relationship among them. And on the second hand, the impact of this type of technology on the healthcare system at all, so in a more holistic way. I hope that this type of presentation will help you to better understand the topic of your work group, and then to suggest you some point of attention in your reflection. So let's start about on the first topic, what is social impact? Social impact is one of the criteria that the OECD, the Organization of Economic Cooperation and Development at international level, defined as the first bullet point of the evaluation criteria of the policy. And when we speak about impact, we are trying to answer a very crucial question. The question is, what difference does the intervention make? So every type of intervention we are thinking to implement in a social context, it may be an educational intervention, a health policy intervention, a social policy intervention. Each type of intervention produces some effects, but there is something that go beyond the effect, the direct effect, is the impact. That is the difference that this intervention introduce in the practices, in the behavior, in the attitude, maybe also in the organizational environment of the context in which the intervention is being implemented. So in the definition at this international level, the impact addresses the ultimate significance and potentially transformative effects of the intervention. The word transformative in this case is very important because it's not just the mechanical effect, it's the transformative effect. It seeks to identify social, environmental, and economic effects of the intervention that are longer term or broader in scope than those already captured under the effectiveness criterion. So this underline more and more what is the vision of the impact. Impact is a way of looking beyond the just immediate effect. Beyond the immediate results, this criterion seeks to capture the indirect, secondary, and potential consequences of the intervention. So reflecting about social impact means that we have to try to grasp information about which are all the possible transformation, all the possible changes that the intervention produce in all the platea, all the actors involved. In the case, we will see in next slides, in the case of medicine technology, the impact of these devices affects not only the patients, not only the health of the patients, but the relationship between the medicine, the relationships between the doctors and the patients, their families, the community, and also the health system as broad. So the last part of this definition shows us that the social impact it does so by examining the holistic and enduring change in systems or norms and potential effects on people's well-being, human rights, gender equality, and environment. So we are in front of a very holistic way of thinking about a transformation introduced by a policy or by an intervention or by, in this case, a family of device. In general, in planning studies and in evaluation studies, we speak about impact as the last part of the impact pathway, what we call impact pathway. There is several phases in which the program can be divided, articulated. If you participate in classes about program management, you are familiar with the first part of this slide. In every intervention, we have to manage firstly the impulse factors, and then we have to arrange how the impulse factors transform itself in activities, produce or realize activities, and how these activities produce results. But results is not a unique word, a unique concept, because results can be different things. There are very immediate results, the outputs, what we produce. And then we have more broader results, the outcomes, that can be the benefits, but also can be the transformation that some actors mature in a certain way, develop in their attitudes, in their way of thinking about people and about their behavior, and also in organization environment. And then at the last part, the long-term impact. So what happens in the community if the intervention realize all the outcome he would like to realize. So in this slide, I present the complexity of reflection about social impact. We can transform the impact pathway in this different way that in a certain can be assumed as the figure, and there is a metaphor under this slide. This metaphor of the stone that you can put into the water. There are the first circle, the very immediate circle of the effect produced by the stone, by the activities realized by the program. That is what is called the results according to the area of control. Generally speaking, the activities produce some effects on the personnel. For example, in the implementation on medical technology, the first effect is to reorganize the scheduling plan of the daily activities of the personnel, or make some opportunity to reorganize the implementation of the routinary activities. So these are the immediate effect in the area in which the program controls itself very much. But there are other outcomes, a second level of outcomes, the second circle produced by the stone into the water, that is the area of influence. What I mean is that the activities and the first result influence in a certain way the attitudes, the behavior of some agents. For example, it can stimulate some opportunities in the personnel. For example, the opportunity to have more time, or the will to understand better some technological device. So we are seeing a certain changing into the behavior of personnel or of patients or of the relationships among them, the network, the way in which the network of kinship, of the network of friends of the patient can help him or her. So the second circle represents the first step of the impact, the outcome that are generating from the activities. And then we will finally arrive to the third and the last circle, in which the activity operating through the behavioral change of the actors introduce some transformation in a very broader dimension into the community, into the, for example, the hospital system, or into the way in which the health care system is organized at territorial or at least national level. These are the real impacts. So taking this in mind, we can tackle directly the second part of our conversation. So the real topic of your interest, so the medicine technology. What is medicine technology? Please feel free to stop me and to pose the question you need, because maybe that I can be not clear, or some concept can be more obscure for you. My English is not so fine, so many things can disturb you. So please feel free to interrupt and to pose the questions. Okay, go ahead with this slide. What is medicine technology? We are used to conceptualize medicine technology in a unique and very simple way. All the technical devices that we can use in medicine. Me, firstly, before starting to prepare this presentation, I was thinking about in this way. But there is a very large part of the literature that help us to divide, to split different levels of medicine technology, and this is very important. There is a first level, the little one that you see at the bottom, that is a more common idea of medicine technology. We are speaking about indirect use gatekeeper technologies. So some devices that are accessed by the gatekeepers and used by someone else than the end user. So technology that arrive to the patient, to me, from other people, and that are used by other people. For example, angiography, CT, dialysis, defibrillators. There are several devices that help our healthcare but are used, manipulated, activated by other people, are completely external from me. But there are other generation of medicine technology. The second generation, is represented by devices that are used by gatekeepers, are accessed by gatekeepers and used by end users. So this type of medicine technology is called direct use gatekeeper technology. I can use this technology, I as a patient can use with the help of a gatekeeper that make me access, help me to access this. In this case can be the prescription drugs devices or the metered dose inhalers. They need a starting point from a gatekeeper, but then I can use by myself. A third generation of medicine technology are very futuristic from my point of view, but are more familiar with you, surely with Carmelo. The direct end user technology. There are technology that are accessed and used directly by end user. So there are devices that each patient can take for himself, can use, can manipulate, and help each one to have information, or especially in diagnostics, helping to have information and to report information to the health system. For example, the health portals, the internet sites or apps, the wearable consumer technologies. There are many devices of this type. So in this analysis, we find that there can be different barriers, different problems according with the more closer or distance between the patient and the technologies. There is a crucial distance. The more the medicine technology is external to the patient, the more can be some barriers. Let's try now to outline an articulation, a schema, in order to analyze the social impact of medicine technology. Taking in mind what we have said just until now, this outline can move us, firstly, to reflect about the access, the adoption of medicine technology, and to reflect that this type of access is not to be taken for granted, because it depends on the action of barriers and enable factors. It depends on the type of medicine technology, but in general, the literature focus about the presence of individual, social, political barriers. At the same time, individual, social, political enablers factors that mediate in a certain way the access of medicine technology. The second point will be the introduction of medicine technology, and maybe about how the introduction of medicine technology produces some outcomes, both in doctors' attitudes and in patient attitudes. So depending on the role of barriers or enablers factors, these medicine technology create some opportunities for the doctors and on the other side for the patients, and these produce some outcomes, some changes. If you remember the slide about the tree circle, we are in the middle part. We are in this second bullet point. We are thinking about how the activity, the intervention of medicine technology introduce some transformation, some behavioral change in these two very strategic actors. Thirdly, and lastly, the third point is about how these outcomes are generating different mid and long-term impact. In what? impact on the doctor's-patient relationship on one side and on healthcare system on the second side. So this will be the outline of my presentation, next part of this presentation, that I will offer you as a review of the main literature about this topic, hoping that this presentation can just suggest you some questions, some reflection about how it not be to taken for granted the introduction of medicine technology, because it depends on the context, the social context, the cultural context, the political context. And so this environment are part, in a certain way, of the impact of the medicine technology. Is that all right until now?
Yes.
Okay, thanks. Well, let's start about the point of view of the doctors. And let's try to in-depth the analysis about the barriers, the enable factors, and the outcome in doctors' attitude. There are several studies, especially this one about telemedicine, in which are explained the four main barriers in doctor attitudes to technical medicine technology. So the first barrier is about technological barrier. The clinicians do not trust technologies if their technical reliability is not accompanied by clinical reliability. So there is a certain first diffidence about this type of technologies waiting for clinical evidence. This is a first component of the professional background of doctors. There is a second barrier. It depends on the system, the economic barriers. In general, in public-driven healthcare system, the costs may represent a barrier. On the contrary, in private-driven healthcare system are the benefits that can represent a barrier. So doctors belonging to public-driven or private-driven healthcare system can develop different attitudes in order to access or conceptualizing of medicine technology. Third barriers is organizational barriers. The needs for procedures able to integrate medical technology into the existing organizational setting. There is, of course, an organizational cost in introducing medical technology, and this can represent an organizational barriers. And the fourth one, behavioral barriers. There is a burden of learning how to change user behaviors and manage resistance, also from doctors' point of view. So these are the first type of barriers that literature presents to us. But fortunately, there are also some enable factors. There are some leverage of diffusion of ECT and medical innovation. The first one is has been captured by a historical study from Coleman, Katz, and Menzel about the innovation, the medical innovation in medicine. And they unveil that the role of professional networks in order to support the medical innovation. They demonstrate that the doctor's decision to adopt medical innovation is strongly influenced by social or professional networks. The rate of adoption accelerates to produce an increasing gap between integrated and isolated doctors. In integrated doctors, so the doctors that work into a community, into an hospital, for example, the rate of adoption of innovation starts very slowly, but after a very short time is grow very, very fast as a S-shaped curve. On the contrary, the isolated doctor that have to inform themselves alone by their own instruments, reading articles, participating in conferences, the growth is continuous but slower than the previous one. So the professional networks represent an environment that enable doctors to accept innovation. And the second point suggested in the literature is the role of negotiation environment. So the fact that innovation needs in a certain way to create a niche, need to create an environment in which doctors can discuss, renegotiate in a certain way to redefine the attitude toward the medical innovation. As Berg and Berg wrote, the implementation of a technological innovation move firstly through the creation of a niche in which the use of the instrument can mature. This is the first part, is very important. A niche in which the use of the instrument can mature. And then through a continuous negotiation with all the elements that support the practice itself. So a negotiation among human elements, diagnostic tools, decisional processes, administrative tasks. We have to redefine all the environment. So the presence of networks and the possibility to mature the decision to implement technological innovation in a niche can represent enabled factors. But what these barriers or what enable factors produce in the general attitude of the doctors, which are the outcomes that at the end we can detect in a certain way in doctor attitudes influenced by these type of factors? Well, the impact of medicine technology move as a part of the general transformation of doctor-patient relationships, and in particular on the role of the doctor, a role that is changing from a bureaucratic authority in the past, a sacred knowledge. This shift from bureaucratic authority to professional superiority, as in a certain way the owner of a specialized knowledge, to deprofessionalization. This is the last point. What we mean with deprofessionalization is a very interesting article from Hogue. Deprofessionalization is a transformation of the profession of the doctors in consequence of the loss of the monopoly of knowledge. Is not only the only owner of the knowledge is more diffuse. And the second point, the loss of exclusive trust from their patients. Patients trust in doctors, but trust also in TV, trust in article, trust in internet. So this can be a problem, of course. And thirdly, the loss of expectation of autonomy at works and expectation of authority of the patients. This authority belong to the exclusivity of the diagnosis. Now the diagnosis is more complex, more diffuse. So in a certain way, the role of doctors is transformed by the general transformation of our time and became more deprofessionalizated. This is the first outcome. We will see it at the end of my presentation. Now move to the patient point of view. Let's see which are the barriers, the enablers factor and the outcome that from the patient side can in a certain way can be applied to the introduction of medicine technology. Which are the main barriers in patient attitudes toward medicine technology? The first one belongs to the impersonality of this type of devices. Some study about telemedicine reveal some hesitation and reveal that this type of hesitation derives from interacting with a physically absent specialist. So this type of technology are impersonal. And this impersonality represent a physically absence of the specialist, and so this produces some type of hesitation. Second is a lack of non-verbal behavior and physical contact. We all experienced this type of hesitation in a certain way during the pandemic. We have started to speak with our doctors through the phone, to receive information through the internet, and this type of impersonality, of course, can represent a barrier. The second one are the barrier depending from approaching to machine, especially in humanoid robots assisted healthcare. That are the radical form of medicine technology. The patient can be skeptical because of technical problems, robots' limited capabilities, and negative preconception. There are this type of evidence and also prejudice that depends on the machine, depending on the type of robots in this case. These can be barriers, but this barrier can be higher or lower depending on social inequalities. Because social inequalities affect the access and the use of direct end users of medicine technology. For example, lower socioeconomic groups have restricted access and use of digital ECT of medicine technology. There are less opportunity to use, less resource in order to use them, but also less cultural instruments in order to appreciate and to access them. For example, the second point, access to technology for disadvantaged people is unstable and can be regularly disrupted. There is less continuity in the use, or on the other side, lower socioeconomic groups are slowest to adopt and benefit from innovative medical technology. And the fourth, and from my side, very important point, more important point, is the literacy or illiteracy. The health illiteracy or the loss of capability in order to understand the benefits, understand also the possibility to use correctly the medicine technology, weakens the ability to evaluate the information needed to use medical services and to make a health-related decision. So this is a very important problem because lower socioeconomic group, disadvantaged groups, illiterate groups are very negatively affected by medicine technology. These social inequalities that produce impact on the use and the access of medicine technology are leveraged by political and institutional barriers too. This second level of influence of barriers influence the distribution in access and use of medical technology across social strata. For example, the healthcare model can influence the diffusion of medical technology. There are parts of the literature that explain how non-minority service healthcare, elite healthcare systems improve the access to medical technology and at the same time prevent general services of this type of instruments, of devices. Also, the political orientation of the governing parties can influence how innovative health technology are accessed and used at the state level, for example. A more statalistic interpretation of the health governance or a private liberal interpretation of the state government can influence the availability of this type of device. Even the social policy itself can leverage differentiated socioeconomic conditions that produce unequal access and use of innovative health technologies. Think about the irregular migrants or homeless. The specific social policy for this type of category can prevent the introduction and the use of these devices to this audience. And last one, there is a last barrier, depending from political and institutional barrier, the cumulative effect of the social distinction, what in sociology Merton called St. Matthew paradox. The more you have, the more you will have. The cumulative effect of multiple technology adopted over time is itself a mechanism for reproduction health disparities. People that are used to have access to technologies, of course, accumulate in a certain way a more confidence, a more trust in this type of technology. On the contrary, people that have been divided, have not the same confidence, do not, in a certain way, accumulate the negative effect against this. But we have also some enablers factor that can moderate the effect of the previous one. There is this very interesting study I found about which are the main factors that can help in a certain way to leverage the acceptance, so the access and the use of e-health. In this picture, you can find the very schematical representation of the links between the different factors. The first factors of the e-health acceptance is represented by the promotional conditions. So the level of advertising, the social references. This promotional condition demonstrated a very helpful leverage in accepting e-health in the case of rural end user in developing countries. This is very interesting. Promotional condition. The second one depend on attitude toward e-health. So the perceived usefulness, the perceived easy of use is important to that medical technologies can be represented as easy to use. The perceived privacy, this is another question very important that have to be demonstrated, and people may have to trust about their privacy. And also, and the last one, the perceived lower costs. So the attitude toward e-health represents the second important factors. The third one are the facilitating conditions. For example, the cell phone ownership. If you have not any device, you can use this type, many type of medicine technology. And fourth, perceived system effectiveness. So the delivery time, the quality, the result demonstrability. So these are the main factors that help the access and in a certain way support the trust to medicine technology. Of course, these enables factors can moderate but not neutralize in a certain way the barriers that we discussed before. Another type of enablers depends on the way in which this type of medicine technology can be introduced and offered to the end user. For example, a study of Papadopoulos about the humanoid robots acceptance underline how the enjoyment, for example, can help the acceptance, the kindness, the comfort, the usability, intuitiveness, easiness, the possibility to personalize, the personalization, adaptability to users' tastes and preferences, care needs, routines. Of course, this belongs to the personal side of enablers, not about the social, not about the political one, but these are important at the same level at the other. Second enablers is digital technology complexities, simplifying treatment regimes, reducing inequalities. So in context strongly affected by illiteracy, for example, and ECT illiteracy, the enforced to simplifying the treatments, the enforced to transform this medicine technology in very friendly and easy to use devices can help in a certain way to reduce the social inequalities that are responsible for as a barrier. Generally speaking, which are the main outcomes in patient attitudes? Previously, we discussed about the deprofessionalization of the doctors. On the other side of this deprofessionalization of the doctors is represented by these two outcomes on the patient's attitudes. The first one is secularization. Secularization is a process according to which we assist to the strengthening of the secular system, the subjectivization of the medicine, the increasing of the possibility for self-care. Secularization means in a certain way individualization. The loss of a certain way of completely belonging to the sacred dimension of the medicine, and responsabilization about the possibility to decide himself for our personal health. This is a general process. The second process, the second outcome of all barriers and enablers factors that we discussed before is in a certain way twofold. On the one hand, the doctor-patient relationships was unstructured in a wide network of devices, ET infrastructures, operators, users, caregivers. So we are in front of a new environment of health service in which through which the patient have to learn how to surf, how to move, grasping information from each part, taken together and used for itself. And on the other side, this positive attitude can transform in a negative one, for example, because the doctor-patient relationship can become conflictual. It represents the necessity to negotiate between different points of view. And unfortunately, we assisted during the pandemic in the increase of, for example, self-care, of no-vax, of contrasting the official evidence from the medicine that are supported by this type of attitudes that has increased during the decades. Third and last one is a positive outcome in a certain way, the possibility to create online peer communities. So patients can organize a new way of discuss or define the healthcare system. Peer communities among patients, but also peer communities that involve patients, doctors, health systems. We will see at the end of the presentation as one of the impacts, the possibility of co-construction of healthcare. Let's see in the last part the impacts on doctor-patient relationships and then on healthcare system. The impacts on doctor-patient relationships move the way in which medicine affect our everyday life from a traditional relationships in which the doctor-patient relationships is inspired by asymmetry, professional knowledge of the medicine, exclusive competence, neutrality, universality, versus secular opinion of the patient, patient weakness, emotional environment, technical incompetence. This is the traditional way in which medicine face the patients. This is the definition from Talcott Parsons in 1951. And the second one is the the decrease of the confidence in the expert system. Medicine was an expert system that give guarantees of reaching the patient's expectation. This type of confidence, this type of trust is put into discussion from all these devices, and especially the possibility for the patient to organize themselves part of their health strategy. The new relationships that is emerging, also thanks to medicine technology introduction, and especially thanks to the possibility to self-organizing the health care in a certain way, is these two different levels, disintermediation and individualization. What disintermediation means? Disintermediation is the fact that companies in the healthcare market address the patient directly without the mediation of the doctors. But at the same time, it happened the reverse. So patients have access to healthcare knowledge and devices without the mediation of the doctors. I'm not arguing that this is negative or positive. This is a fact. This is a changing in the relationship between doctors and patients. And medicine technology can, in a certain way, enforce and strengthen this type of disintermediation. The second impacts is what we call individualization or privatization. That can be in this case, two different impacts. A negative one, firstly, and a positive one, secondly. The negative one, according to the neoliberal logic, this individualization means that individuals became responsible and can activate the patient as clients. In a certain way, this individualization is a privatization of the possibility to trust about and to use medicine and leave the people alone. So a certain of loneliness. In a positive way, individualization means that there is more control on healthcare information from part of the patients. Patients can be part of the healthcare strategy. Is what part of the literature called democratization of medicine, a new relationship between patients and doctors in order to empower the patients and to involve the patients into the healthcare. In this case, medicine technology can help this positive type of impact. In fact, this is the last one, the impacts on the healthcare system. There are three main impacts. The first impact is the increasing demand for services. This is a paradox of medicine. It ever happened. The progress of knowledge increased the demand for services, but also the dissatisfaction. At the same time, demand and dissatisfaction, because life gets longer in a context of deterioration of its quality. But the second impacts, not only the increase of demands, but the second impacts is the change of the healthcare model from hospital-centric to patient-centric. The second side, the patient-centric healthcare model, is very important because in generally it low the costs and grow up the quality of services. The new focus are on prevention, are on long life assistance, and also on the possibility for patients to participate in the implementation of health strategies. And in these second impacts, medicine technology are very important. The third one is what I introduced before, is the democratization of medicine. Not only from the side of the generation of data, the patient-generated data, that is very important. In your winter school, I think that you analyzed very much also the topic of big data, of open data. This is a very useful topic in order also to understand the democratization of medicine, but also the co-production of health, the involvement of people in using devices and in participating actively and responsibly in a responsible way in the healthcare strategies. Fine, I finished my presentation. I hope that this presentation has been of certain use and can be helpful for you. So I thank you and leave the ground for some questions and comments.
Thank you, Gabriele. Really, really interesting. I have a couple of questions, but first, students, if you have any question. Any question, guys? So I have a question, but let's say a practical question. So, like evaluating the outcome, not the impact, but the outcome, which is like the best instruments? I don't know, interviews, questionnaire, opinion leader. So if I have to somehow measure the outcome, how can I do?
Okay, generally in evaluating literature, the outcome can be grasped through qualitative inquiry. So you need generally the stakeholder analysis. So interview to the stakeholder of a system, opinion leader, but on the ground. So if we want to analyze, for example, the outcome of the introduction of medicine technology in a place like Pisa, the Pisa district, we have to interview the main doctors of the different divisions, some representative of the association, local association, some familia, some patients, and we can do individual interview or also collective interview like focus group, for example. And there are some in literature, we have some some pathway, some strategies of investigating this. For example, we in the Department of Political Science in Pisa, we use outcome harvesting model. That is a way to come back to the field in order to ask what has happened. And asking what has happened make us able to put in evidence some outcomes, some evidence of outcomes that we have to triangulate with other type of evidence in order to focus about it.
Okay, thanks. And just let's say another question, because I'm really interested in the topic. Regarding the impact, I saw the first papers you cited about the doctors, so healthcare providers were, I mean, many of them were, well, I say, 40 years ago, sometimes. So, which is like the horizon for evaluating the impact? Like 20 years? So, how long is?
This is difficult to answer. Generally, the impact evaluation means to analyze statistically how variables and output variables move, and generally we organize a counterfactual analysis of treatment and non-treatment, treated group and non-treated group. I have not experience of impact analysis in healthcare systems. In social system, generally, we move in 2-5 years, no more than that, because when you wait too much time, many other things can happen in between. So there can be other programs that are implementing some changes depending on other things that the program you are looking for.
Okay. Thanks, Gabriele. Just to, just for stimulating the discussion, also giving some input to students. There was like a teacher from my school that was explaining to their students that in the Middle Age, the tools that you start learning at the beginning of your career were the same when you finish the career. And this was the same more or less for 300 to 400 years. Now that, we started doing this job, and I was writing with my pen. Now I'm not using the pen anymore. And it was just 10 years ago. So the fact that the tools and the technology is changing so fast, so it's something that could be considered or should be considered in the policies and in the way we evaluate the job of people and the way we are seen from other people, including doctors and patients. So this is just for concluding.
That's completely right, but we have to take in mind that not for all the people is the same. We have a social stratification of people. So this innovation is more confident with middle class literated people. For elderly people, for poor people, for people living in rural area, can be not the same. So we have to take in mind this. So for this reason, many studies I've mentioned underline the fact that we have barriers to the access of medicine technology depending on social belonging of people and class structure and so on.
Yes, probably right. So, guys, I want to say thank you again to Professor Tomei to participate in this school, giving like a different point of view, a different perspective to medical technologies, like analyzing the relationship between patients, doctors, mediated by the innovation in medical device. So, thank you again, Gabriele, and
thank you,
guys. This is the moment for our lunch break. We will see you later in the afternoon at 2:30 p.m. Am I right? So thanks again and bye-bye.
Bye.